Dr. Elwing, you mentioned that bosentan and macitentan have shown some efficacy in treating portopulmonary hypertension, but are there any other approved pulmonary hypertension medications which show to be effective?
So that is a very good question, but a tricky answer. We can use our currently available medications for pulmonary arterial hypertension in our liver disease patients, but we don't have specific randomized controlled trials to help guide us on that, okay? It is a WHO Group 1 type of pulmonary arterial hypertension, so that we do have FDA indicated medications. So we can get the drugs approved and use them, but we have to use caution and our clinical experience to guide us. So if we want to specifically talk about certain kinds of medications, the PDE5s, we have small series of patients who've been treated with those medications safely, and we frequently use that in our clinical care of our portopulmonary hypertension patients here at Cincinnati. Now there is a newer drug called Riociguat. We really don't have a lot of data on that medication in our portopulmonary hypertension patients, so something that we need greater study on. When our patients are sick, their hemodynamics are advanced, we do use prostacyclins. We can use them orally, inhaled, IV, and sub-Q, and those patients are treated as an N of 1. We treat them, watch them carefully, and make sure we have hemodynamic success. The problem is those patients have not been well studied either. We do have several case series and patient reports that showed successful use, and one I'd like to point you to is a study from 2004 that really encouraged our use of these medications and showed us that we could safely implement the prostacyclin treatment pathway to have improvement in hemodynamics to allow successful liver transplant. In this individual, they underwent treatment with iloprost, which is a drug used not in the US but other places in the world, treated intravenously with improvement in hemodynamics, allowing transplant, and successfully coming off medications post-transplant, which is our ultimate goal, to get patients to be pulmonary hypertension free at the time of maybe 6 to 12 months post-transplant. It doesn't happen for everyone, but that's what we always are hopeful for.
Now, how common is an outcome like this patient had?
In my experience, working with the liver transplant program here, I frequently see patients that were able to diagnose, treat aggressively, and then fully wean off their IV or subcutaneous therapies. We have probably successfully treated more than 20, 25 patients working with the liver transplant program, successfully getting those patients transplanted. Now, we do have a small fraction of patients we continue to follow on oral therapies, and that's something we've seen here and has been seen in many other centers, that there is a small group of patients that their portopulmonary hypertension does not fully resolve. Another interesting thing we've seen, it's reported in the literature also, we see patients that are diagnosed with portopulmonary hypertension after transplant, which is a very interesting, very complicated situation, but we were treating them as we would any other pulmonary arterial hypertension patient, watching them closely and thinking always we do not want to hurt their liver in the process.
So you have a mixed bag in terms of therapy and effects on survival in patients.
Yes, we do. We do. And we don't have a lot of data to say one therapy is better than another. And I choose which therapy based on the patient. When we are talking about a patient that's very ill, that has high risk of having complications because of their medications, I will choose a regimen that's easy for them to follow and that I think is the safest option for them. Now, if I have a young individual who has a very supportive family and that does not have too much trouble with encephalopathy or that haziness you get because of liver disease, that person can have any of our therapies. They can have an intravenous line and continuous infusion therapy. Whereas a person that doesn't have as much social support or has very difficult time with becoming confused, They might, if they have to have infusion therapy, be a better candidate for a subcutaneous infusion rather than the IV because of the complexities of managing an IV independently at home. Because recall that this disease is the only disease that we can be on these IV therapies for extended periods of time, and patients are using these highly active medications on their own at home. So we've got to make sure they're safe, and we've got to choose the therapy that will get them to their goals but also not get them in trouble with safety.
Well said.
Thank
you,
you.
Doc.